Confidently lead AI integration in your practice with practical, clinically focused strategies. Join RSNA in Barcelona, Spain, October 16th through 17th for Radiology Reimagined, Advancing Clinical Practice Through AI Innovation. This 2-day course delivers case-based learning, expert-led Q&A, and real-world implementation guidance to help you evaluate and apply AI. Register today at rsna.org/Barcelona.
Hello and welcome to another entry in the RSNA Radiographics podcast series. My name is Shravan Sridhar and I'm an assistant professor in cardiothoracic imaging at the University of California, San Francisco. Today we'll be discussing the radiographics article entitled Evidence-Based Approach to the Performance, Risks, and Controversies of Transthoracic Needle Biopsy by myself and colleagues. Whether you're a radiology resident, fellow, or practicing radiologist who performs transthoracic needle biopsy, or you're just curious to learn more about the current body of evidence on this procedure, we'll take this opportunity to cover everything from patient selection to complication management and building an evidence-based transthoracic needle biopsy service. So what's the big picture? Well, let's start with why transthoracic needle biopsy matters. This procedure has been increasing in utilization with a 6-fold increase in the U.S. just between 2001 and 2010, and the number of hospitals offering this procedure has nearly doubled over the same period. While more recent large-scale studies are difficult to come by, extrapolation suggests further growth in utilization. And when any procedure is used more frequently, it becomes important to ensure that we understand its indications. Transthoracic needle biopsy can be used for initial diagnosis of an indeterminate lung or mediastinal lesion, staging workup for known cancers, monitoring treatment response, and even diagnosing unusual infections when standard cultures come up negative. And interestingly, transthoracic needle biopsy is increasingly used for transplant candidates, where a suspicious lesion could mean the difference between staying on or being removed from the transplant list. So very consequential. And in the era of personalized medicine, we're also characterizing molecular profiles that guide targeted therapies. Think EGFR mutations, PTEN alterations, and other actionable genetic markers that can alter a patient's treatment course. Now that we understand what can be achieved with transthoracic needle biopsy, let's talk about some of the foundations of successful transthoracic needle biopsy procedures, which begins with proper patient selection. There are 6 features of patient selection that every proceduralist should evaluate before approving any biopsy request. First, clinical scenario and indications. In the setting of diagnosing malignancy, we're looking for that sweet spot, lesions with an intermediate pretest probability of malignancy that ranges from 10 to 70%. If the pretest probability is much lower, we're unlikely to find cancer, but if it's much higher in certain cases, it may be appropriate to skip straight to treatment. As we discussed before, there are many indications beyond malignancy diagnosis still under the umbrella of cancer care, including restaging, confirming or rejecting recurrence, and acquiring tissue for molecular profiling that can help identify targeted therapies or investigate mutations that lead to chemoresistance. Transthoracic needle biopsy can also be used for workup of infection, typically in cases where the infection is refractory to treatment. Second, time course matters. In the setting of a new indeterminate lesion, if there's no prior imaging, it's advisable to consider a 1 to 3 month follow-up CT first. Rapidly growing lesions often represent infection, while persistent or slow-growing lesions raise a red flag for malignancy. Third, lesion size directly impacts success. Diagnostic accuracy ranges from 67% for subcentimeter lesions up to 100% for larger masses over 5 centimeters. But location also matters. Apical lesions are typically easier targets due to less respiratory motion, while lesions that are located near the diaphragm or the heart can be more challenging to access due to breath-to-breath variability. Fourth, lesion density is crucial. Necrotic or cystic lesions with minimal soft tissue typically yield poor results. And this is where PET-CT becomes your friend, and it can help identify the viable metabolically active portions that are worth targeting. And sometimes contrast-enhanced CT can also serve a similar purpose, identify areas of viable tumor that can be sampled. Fifth, lesion location affects both feasibility and risk. Subpleural lesions are easier to access but may have higher pneumothorax risk if they're close to but not touching the pleura. For example, if you've got, let's say, a small 1 centimeter lesion that's located 6 millimeters from the pleura and the only trajectory you can take allows less than 1 centimeter of purchase of the needle in the lung, it's possible that your needle might back out into the pleural space in the course of biopsy and result in more than one pleural puncture, increasing the chance of a pneumothorax. And finally, patient risk factors. This includes bleeding disorders, anticoagulation status, emphysema, pulmonary hypertension, and other risk factors, all of which influence your risk-benefit calculation. Now that we understand how to complete the pre-procedural evaluation for transthoracic needle biopsy, let's discuss performance metrics and techniques. And let's start with the numbers. For malignancy diagnosis, transthoracic needle biopsy delivers sensitivity over 77% and specificity over 93%. The positive predictive value is excellent at over 96%, meaning if you get a positive result for malignancy, you can be very confident that it is a malignancy. However, the negative predictive value ranges just around 51 to 84%. So a negative biopsy for malignancy doesn't definitively rule out malignancy. That brings us to the non-diagnostic rate, which is 17 to 28%. And you might be wondering what predicts a non-diagnostic result. Well, needle tip located outside the lesion, procedures lasting over 60 minutes, alveolar hemorrhage, needle traversal through emphysema, and lesions 15 millimeters or smaller are all predictive of a non-diagnostic result. But here's something that's encouraging. Repeat biopsy after an initial non-diagnostic result can in fact be worthwhile. About 54% of initially non-diagnostic biopsies yield diagnostic results on second attempt, and this jumps to 63% when the first biopsy showed atypical cells. So what does this mean in practice? Well, in the setting of a biopsy being performed to investigate an indeterminate lesion, if the biopsy comes back non-diagnostic, you need to have a discussion with the ordering physician about the results, and the first question you should ask is whether the risk-benefit calculus still favors doing another biopsy, or perhaps it might be better to repeat a CT if the lesion was on the lower end of the spectrum of pretest probability for malignancy on the most recent CT. Particularly if the patient is not interested in going through with a repeat biopsy. So let's say that the indeterminate lesion is somewhat concerning for malignancy, around 70% pretest probability, and the patient is okay with a repeat biopsy attempt. In this case, it might be worthwhile attempting to repeat the biopsy. And at this point, you should ask yourself what, if any, modifiable factors impacting success of the first biopsy can be addressed during the second biopsy. For example, maybe the patient had a lot of chronic pain and couldn't hold the position on the table, causing you to have to abort the biopsy or have difficulty with targeting. In this case, better preoperative pain management or involvement of an anesthesiologist during the repeat procedure may help increase the chance of a successful repeat biopsy. Technical considerations also matter. Needle gauge affects both complications and yield. Larger needles increase the risk of pneumothorax but improve tissue adequacy, especially for molecular testing. An 18-gauge needle provides about 5 to 6 times higher yield than a 20-gauge needle, and performing 2 passes doubles the yield compared to 1 pass. The core needle biopsy versus fine needle aspiration debate continues on, but recent evidence suggests that core needle biopsy has lower non-diagnostic rates at 13% compared to 45% non-diagnostic rate for fine needle aspiration alone. And if you have access to rapid on-site evaluation by pathology, it's advisable to use that service. Now, rapid on-site evaluation improves diagnostic accuracy from 83 to 94%. That's about 10% increase in diagnostic accuracy, so definitely nothing to scoff at. But you have to keep in mind that using rapid on-site evaluation increases overall procedure time and not all centers have the luxury of having pathology on site and aren't necessarily going to be able to accommodate the logistics that are required. So bottom line, transthoracic needle biopsy has a pretty high sensitivity and specificity for diagnosis of malignancy, has a relatively low non-diagnostic rate, and we can optimize our technique to reduce that rate further. Now let's talk about complications and risk mitigation. Complications are what give us anxiety, but often we're anxious and fearful when we don't quite understand the chance of an undesired outcome or how to avoid undesired outcomes. Pneumothorax tops the list of complications at about 27% incidence, though most pneumothoraces that we encounter are small and they're often asymptomatic. What's more important is the chest tube insertion rate, which is about 5 to 14%. Risk factors for pneumothorax include small lesion size. Lesions that are under 2 centimeters are 10 times more likely to be associated with pneumothorax than those that are over 4 centimeters. Lesions within 2 centimeters of the pleura but not touching the pleura are 7 times more likely to be associated with pneumothorax than lesions that touch the pleura. Crossing bullae or fissures dramatically increases the chest tube insertion risk. But the good news is that we have proven risk mitigation techniques. The pleura to lesion angle technique suggests using a trajectory that is as close to perpendicular to the pleural surface as possible. The intraparenchymal saline or autologous blood patch technique can reduce pneumothorax rates by up to 15% and chest tube insertion rates by 9-fold. The rapid rollover technique, which involves getting patients biopsy side down within 10 seconds of needle removal, reduces pneumothorax rates from 37% to 23%. The Pearl technique combines multiple approaches to reduce pneumothorax risk. Pearl, or PARL, is an acronym that stands for Positioning Biopsy Side Down, Expiratory Needle Removal, Autologous Blood Patch, Rapid Rollover, and pleural patch application. With the use of the Pearl technique, pneumothorax rates dropped from 37% to 16%, and chest tube insertion rates from 13% to just 1%. Hemorrhage is another potential complication of transthoracic needle biopsy and is typically self-limiting. A small amount of perilesional hemorrhage is within expectation following biopsy. A significant amount of hemorrhage can produce hemoptysis, and if a patient develops hemoptysis, it's a good idea to provide prompt supportive care, including oxygen and airway suctioning as necessary. Hemothorax and thoracic wall hematomas can result from extrapulmonary vascular injury. The risk of significant hemorrhage can be reduced by carefully planning the biopsy trajectory such that no major vessels are located along the trajectory or close to the introducer terminus within the chest wall, lung, or mediastinum. And sometimes contrast administration for the pre-procedural planning CT is helpful in this regard. It's important to note that careful selection of patients and management of anticoagulation with pre-procedural PT-INR and platelet measurement is important. You can refer to the Society of Interventional Radiology guidelines on management of thrombotic and bleeding risk in patients undergoing percutaneous image-guided interventions for further details. Transthoracic needle biopsy also has some less common but serious complications, mainly air embolism, which occurs in less than 0.2% of cases. Risk factors for air embolism include prone positioning and lesions above the level of the left atrium in the vertical direction. So why is that? The theory is that there's lower pressure in the pulmonary veins located above the left atrium, making it easier for air to enter the pulmonary veins. For example, if you have a patient in the prone position and there's a lesion in the posterior-most portion of the right lung, and therefore the highest point above the left atrium that you're going to get, theoretically, if a pulmonary vein is crossed in this location, there's a higher risk of air embolism than if a pulmonary vein is crossed at a location where it runs at the level of the left atrium. So then let's say you place the patient in a position such that the patient is prone but kind of rotated a little bit onto their left side, such that the right lung is higher relative to the left lung. Theoretically, you're further decreasing the pressure in the posterior-most portion of the right lung. So this tells us that using a combination of lesion selection, trajectory selection, and patient positioning can potentially help reduce the risk of air embolism. But sometimes, despite our best efforts, the patient ends up with an air embolism. So if you discover that your patient has developed an air embolism, it's advisable to place them in a position that traps the bubble of air in such a way that it does not migrate any further antegrade. So how you rotate the patient depends on where the air embolism is located. But regardless of location, placement in a position with the head positioned lower than the feet can help protect against embolization of air into the cranial vasculature. An even rarer risk is death, which occurs in less than 0.02% of cases and is usually due to massive hemorrhage or air embolism. But given how rare this outcome is, the risk-benefit calculus still often favors proceeding with the biopsy when it's indicated. Similarly, tumor seeding along the needle tract is exceedingly rare, reported in under 0.6% of cases. And patients can understandably be worried about the potential of malignancy spreading as a result of the biopsy procedure. But given how rare this is to happen, the risk-benefit calculus typically favors proceeding when the biopsy is indicated. So now that we recognize complications and some literature-supported risk mitigation techniques, let's tackle some controversial scenarios. Number 1, should we perform biopsy in patients with emphysema? Well, emphysema increases pneumothorax risk by 3-fold overall and chest tube insertion risk by 6-fold. And patients with emphysema along the needle path are 72 times more likely to develop pneumothorax. So it's important to plan a trajectory that avoids emphysema. And if you can't do that, make sure either you or your interventional radiology colleague are ready to place a chest tube if it's needed. As to whether to proceed or not, that's a discussion to be had with the patient and a joint decision between the proceduralist, the clinician, and the patient. Number 2, should we perform biopsy in patients with fibrotic interstitial lung disease? While diagnostic performance in patients with ILD remains good, about 90% sensitive and 84% specific, honeycombing along the needle tract increases the risk of major complications by 11-fold. And based on this, it's advisable to minimize the needle path length and avoid areas of honeycombing when possible in patients with fibrotic interstitial lung disease. Number 3, should we perform biopsy in patients with pulmonary hypertension? Well, this is a tricky one. A study using a 19-gauge introducer and 22-gauge and 20-gauge coaxial core needle biopsy system in a cohort of 74 patients showed no significant difference in the rate of complications between patients with mild to moderate pulmonary hypertension and patients without pulmonary hypertension. But it's possible that the increased risk of hemorrhage in these patients is rare enough not to be captured in a cohort of this size. So the question is, how do you deal with this? I can tell you what our practice is, and we still do perform biopsies in patients with mild to moderate pulmonary hypertension, but we typically schedule these patients at our adult inpatient hospital where we have resources to deal with hemoptysis or hemorrhage if they do occur. Number 4, should we perform biopsy in patients with subsolid nodules? Studies show that these have a 75% probability of representing adenocarcinoma when they persist for 3 months or greater. And given the high pretest probability, many go straight to treatment without biopsy. When biopsy is performed, diagnostic performance is similar to solid nodules, so bottom line, it's advisable to pursue biopsy if it's clinically indicated. For example, if your surgeon would prefer to do a biopsy to confirm malignancy prior to surgery, if the patient's, let's say, not a great operative candidate and the lesion has a relatively high pretest probability of malignancy at, let's just say, 80% or so, but maybe not as high as 95%, then it's fine to go ahead with the biopsy. And finally, number 5, we come to the question of transthoracic needle biopsy versus transbronchial biopsy. Now, transthoracic needle biopsy shows higher diagnostic rates for peripheral nodules of 86% versus 66% for electromagnetic navigation bronchoscopy. However, bronchoscopy excels for central lesions and when mediastinal node staging is necessary. Cost considerations also favor transthoracic needle biopsy, which costs about 40% of what transbronchial biopsy costs. So definitely something to think about. So in closing, transthoracic needle biopsy remains an incredibly valuable diagnostic tool with excellent accuracy and manageable risks when performed thoughtfully. The key takeaways from our discussion today include careful patient selection using evidence-based criteria, appropriate technical considerations including needle choice and complication mitigation techniques, and familiarity with special populations and controversial scenarios revolving around the performance of transthoracic needle biopsy. As our field continues to evolve, it's important for us to stay current with the evidence, and doing so helps us optimize outcomes and serve as effective consultants to our multidisciplinary teams. Thank you for joining me today for this discussion, and I hope you've found this helpful.